hang out. You want to turn your cameras on? We're all friends here.
I
We're all
got you.
colleagues.
All right, there we go.
Okay,
All right, we are good to go when you are.
let me try and share this. Yeah, I'm working off of one screen right now. I hate it. How's everyone doing?
Pretty good, pretty good.
Can you all see my screen?
Yeah,
Yeah.
Okay. So, as Rishi said, I'm Jared. I'm Dr. Mayfield. I'm former Ross graduate. I'm a first year resident at Henry Ford Macomb. And I just came off my neuro slash OB rotation about a month ago. So I figured why not just talk about some obstetric type emergencies. Not going to really focus on gyne too much because it's pretty much straightforward. Stop the bleed, give them estrogen, go to OR, go home. Obstetrics is kind of scary because people like, I mean, let's be honest, pregnancy is scary and things can go south extremely fast. Picture any medical emergency, throw pregnancy on top of it, and it gets like uber worse. Like it gets 1,000 times more of a nightmare. So it's just more of you need repetitions, you need to like know this kind of stuff for when you do see this. On rotations, you may not see stuff like this, but it's still helpful to know. Anybody deal with any obstetric complications on any EM rotations or on OB or anything like that?
I had a EM, no, I'm sorry, not EM, a um emergency when I was on my OB rotation. We had a prolapse, and me and the attending had to jump on the bed, and the attending held the baby up in the patients, and I gowned the attending while they pushed us down, ran us down the hall into
Mm-hmm.
the OR.
Yep. That's just what you got to do.
That's intense. I had a lady that was jumping on a trampoline like 8 months pregnant. I was like, okay. And she fell off and everything was fine, but we were like, yeah, probably shouldn't do that.
Because we'll talk a little bit about obstetric traumas too. But anyways, let's get into it. So a little bit of the overviews. We'll talk about postpartum hemorrhage. It's a little bit applicable to us. Placental abruption. Tie you up for board exams as well. Eclampsia, not super in detail, just what we need to know from the ER setting. Ectopic pregnancies, because they're always going to happen. And then postpartum cardiomyopathy and perimortems, the stuff we all like to talk about. It's cool, it's flashy, but it's you never want to do it. So in regards to postpartum hemorrhage, it's basically defined as up to 6 weeks after, or the postpartum period is defined up to 6 weeks after delivery. And postpartum hemorrhage is defined as 1,000 cc blood loss, whether it's vaginal or C-section, doesn't matter. There's primary postpartum hemorrhage, which is less than 24 hours from the postpartum time frame, and then secondary is 1 day up to 12 weeks postpartum. In the primary postpartum hemorrhage, the most common cause is uterine atony or atony. Um, Typically, this is when you see in like a vaginal delivery, they'll deliver, and then immediately afterwards, after the placenta's out, they're starting oxytocin and they're starting to massage the uterus. It's because of this complication. So you can give Methergin if is used if no hypertension or arterial disease. You can use carboprost if no asthma history, but I'll be honest, I haven't seen that used in a while. And oxytocin is typically started immediately postpartum to prevent this. The secondary cause of is uterine, or the second cause of primary postpartum hemorrhage is uterine inversion. You just treat this by manual reduction, fluid, vital sign therapy, um, as needed. It's usually you don't really see this a whole lot. Secondary postpartum hemorrhage, the most common cause is retained products of conception by way of placental accreta, preterm birth, retained placenta, you treat this with uterotonic agents. Most likely they'll need a DNC. I had a patient who gave birth and then like a week later came in because she had vaginal bleeding, and then we did a speculum exam and she had retained products that we could easily just pull out, but luckily she didn't need a DNC. So this can present like just regular vaginal bleeding or like massive vaginal bleeding. So just be aware. If known to be high risk for postpartum hemorrhage, have 2 wide bore IVs in place. This is mostly when you're doing the rotation when you're a resident. Or if you get the call from EMS, just don't be afraid to throw those 16 gauges. Other considerations for bleeding control, you can use TXA. You can also use TXA in gyne bleeding, and you can balloon tamponade. If anybody knows what a Reboa is in emergency medicine, gyne has something similar that can basically tamponade the cervix to kind of stop the bleed. But we don't have that in the ED, so you just gotta like you have to pack the vagina with a ton of 4x4s to stop the bleed. Placental abruption is complete or partial separation of the placenta from the uterus prior to delivery. Etiologies include hypertension and preeclampsia. Abdominal trauma and even simple trauma, like just turning in the kitchen and just hitting the abdomen on the counter, can cause a placental abruption. Maternal age, less than 20, and if they're over 35, these are risk factors. Clinical symptoms, vaginal bleeding. 1 in 5 patients will have a retroplacental bleed, and you won't have vaginal bleeding. Now, for board exams, they're going to say vaginal bleeding, bright red blood, in either abdominal pain or back pain. And they'll have uterine tenderness. And this is in some form of trauma by way of, I said, simple trauma or like MVC or fall. And you need to basically, they need to go up and talk to gyne or OB. But you look for a potential shock in DIC because if unrecognized, this is a fairly bad complication of trauma in pregnancy. The treatment is stabilization of the mother. You do Toko for the fetus, and you get your OB-GYN consult. Place 2 large bore IVs, CBC, CMP, coags, DIC panel, type and cross, because they're more than likely going to go to the OR for a C-section. If it's severe enough, you need to get the type and cross because, you know, if mother's negative and baby's positive, you have to give ROGAM. And then you want to be aware of like DIC and other complications like HELP syndrome and all those kind of problems. And then yeah, for a severe abruption, you immediately deliver. Anybody have any questions so far? All right, so probably the most common thing that we see in the ED from pregnancy perspective outside of vaginal bleeding in the first trimester is hypertension in pregnancy. And this is a not only step 2 shelf exam favorite, but this is also like intern exam or like in-training exam and EM boards, oral boards favorite too. So chronic hypertension is hypertension in pregnancy prior to 20 weeks of gestation or persisting longer than 12 weeks after gestation. And it's with the blood pressure of 140 on systolic or higher or over 90 diastolic or higher. One or the other or both at the same time meets criteria. It doesn't really matter. Gestational hypertension is hypertension diagnosed at 20 weeks or afterwards. And I believe this says up to 6 weeks postpartum without proteinuria. And then anybody know what medications are safe in pregnancy to treat hypertension? Whether it's chronic or gestational hypertension.
Labetalol's one.
So you got labetalol.
Hydralazines.
Methodopa and
Nifedipine.
nifedipine.
Yeah. So those are the really four ones that you have to use. I'll be honest, nobody uses methyl dopa anymore. And if you ever, I don't know, there's a lot of school of thought that nobody likes hydralazine. I don't like hydralazine for a lot of different things because the variable drop in blood pressure is extremely wide range and doesn't last a long time. So you'll most commonly see patients on labetalol, given labetalol in the hospital, or on nifedipine. And do these 3 to 4 medications, do they cross the placenta at all? Okay, so all blood pressure medication crosses the placenta. These are just safe, that doesn't cause any teratogenic effects that ACEs and ARBs do. Preeclampsia is basically hypertension in pregnancy after the 20th week with proteinuria or end organ damage. If no proteinuria and you have cerebral dysfunction, seizures, altered mental status, pulmonary edema, liver or renal dysfunction, these are criteria for pre-E or preeclampsia. The path, nobody, I mean, people have ideas. Obviously, the one that we know for boards is like they have you have the uterine decidual arteries that kind of, like come in more into, parallel and series and does all this physics and it raises the blood pressure where it can. And it's thought to be atherosis of those arteries and leading to ischemia and infarcts of the placenta. And so you basically get supporting labs. They're your basic labs, CBC, BMP, LFTs. You'll see GYN or OB-GYN. You'll order a lot of UPCs or the urine to protein creatinine ratio. They have these cutoffs. I don't really know how to interpret this, but they order that a lot. And that's really it. Not really much outside of like basic labs though. Yeah. Oh yeah, here they are. So you can get the I guess you can get lactate also. That kind of helps. If you're worried about HELP syndrome. And the protein creatinine ratio, oh, that's like a surrogate for the 24-hour protein collection in the urine. I've never seen a uric acid level ordered, but you can. It helps further support certain diagnoses. So then you have HELP syndrome. This is again any woman 20 weeks of gestation, up to 7 days postpartum with abdominal pain. You should always think about HELP. Because it's right about quadrant pain, the postpartum, they likely have either their baby with them or multiple kids with them, or if they're alone, like you may not know this, but I say this because they're childbearing age, so they may or may not have had their gallbladder taken out and they're already at risk for gallbladder pathology. So you see an otherwise healthy female right about quadrant pain, you're not really going to think of HELP syndrome unless you know specifically that they just gave birth. You're going to be thinking of the 4Cs or anything like that. So you always have to have this in the back of your head, especially if they say, I just gave birth. It is very important to always keep in the back of your head. Yeah, so like I said, it's easy to misdiagnose this demographic with pyelonephritis, cholecystitis, pancreatitis, and you get supporting labs to help. They're the basic same labs. The CBC, BNP, LFTs, that's really it. Like I said, you can get an LDH in this, like if you're concerned for help or if the CBC is concerning, but it's not necessarily needed. So the treatment of pre-E is managed closely with patients OB in the outpatient setting. So return or consult OB-GYN for new headache, scintillating scotoma, visual changes, abdominal pain, bleeding, and decreased fetal movements. And kind of like I've heard this once on my OB rotation. it was always asked like, well, what's decreased fetal movements mean? And it's like you have all these like criteria that like, that some people will say, but it's like less than like 7 to 10 like movements in an hour or something like that. And then you don't just go from that hour, you have to go into the next hour. So there's this very certain criteria that OB will specifically tell these patients. And sometimes they present to the ER for a decreased fetal movement. So you always have to think of hypertension or pre-E. For severe range blood pressures, this is your hypertensive emergency in pregnancy. So it all changes from the, like the greater than 180 over like 110, with or without features. This is 160 or higher over 90 or higher. And either one, if it's at that threshold, it meets criteria for severe range blood pressure, and then you have to go down this whole pathway of basically treatment. Use antihypertensives and IV MAG. The MAG dose is quite large. It's 46 grams IV infusion, followed by 2 grams per hour for 24 hours. So it's a truck ton of MAG. You do regular MAG checks for these patients, and you monitor vital signs, of course, blood pressure, and deep tendon reflexes. When you start to get into the hyper MAG area and MAG toxicity, reflexes are about the first to go. So you do these MAG checks every 2 hours, just to monitor. Like we have already discussed, BP meds, IV labetalol, 20 milligrams initially, and then 40 to 80 Q10 to 20 minutes, up to 300 milligrams. That's IV. You can use PO nifedipine, 10 milligrams IR, repeat every 30 minutes, I think up to 3 times. Hydralazine, 5 mg IV, repeat Q 20 minutes. I'm gonna be honest again, hydralazine is garbage, but you can still select it if you want. If you pick one, you commit to it when max, then you move on to something. You don't do this whole like, oh, I gave like 2 doses of labetalol and then it's not working. I'm gonna try nifedipine. Like, don't do that. That's wrong. Don't answer like that. Um, just pick one and commit. I put IR here for nifedipine because it's very important, because specifically for the treatment of severe range blood pressure, it's IR. You can give Procardia or nifedipine XR, which is wildly different, and it's 30 milligrams. So you have to also pay attention as to what you're putting into the order, because sometimes, like one of the residents told me that when she was an intern, there was like basically a miscommunication, and IR got ordered instead of XR, and then it was 30 IR instead of 30 XR, and then basically this pregnant patient went into hypertensive like shock and then had to go to the ICU. So you just have to be aware of like what you're specifically ordering. That's why I like labetalol. Like you really can't mess that up.
Jared, I think Katie's got a question. Her hand is raised.
Yeah, I see you, Katie. What's up?
Sorry, Jared.
You're fine.
Can you explain IR versus XR? Because I looked it up and I see immediate release versus interventional radiology versus, all these things. So
Extended release, immediate release.
Yeah.
Okay.
Yeah. So so in terms of this context, it's immediate release. And then you'll see pregnant patients on like Procardia 30 XR, and that's just extended release over a 24-hour period. But if you're going to pick nifedipine, like you need to make the distinction between IR and XR, because you can have bad outcomes if you're not really paying attention. Oh, and then also you can do PO labetalol, which I recently learned. The dosing is kind of weird. It's actually kind of high. Like these people are on PO labetalol, like I think they're like on it like up to like 300 3 times a day, like max dose is like 2,000 milligrams in a day. It's actually kind of wild. Yeah. And then the above is the same management for eclampsia, although the only other definitive treatment of eclampsia is obviously we're going to deliver the baby. But you still do the IV mag 4 to 6 grams infusion and all this 2 grams like per hour. It's a lot of mag. Ectopic pregnancy. This this is a very interesting. A lot of OBs, kind of laborists, they have their own ACOG guidelines and then their own like practice anecdotal experience. But basically, in the context of us, pregnancy with implantation outside the uterine cavity is defined as ectopic. Ruptured ectopic is the leading cause of death in mothers in the first trimester. And the major risk factors are prior ectopic, PID, and tubal. So it doesn't matter if a female patient says, I've had a tubal, just like if they're 35 years old, you're still gonna get a UPT on them because they're at the highest risk also of ectopic. PID is a very interesting I don't want to say phenomenon, but it's a very interesting disease state because it's underdiagnosed and it's very frequent out in the general population of America. And it is an extreme risk factor for ectopic pregnancy. Most common areas, the ampulla of the fallopian tube. Very rarely, I think in like less than 1% of ectopics, it's in the abdomen, which is kind of wild to me. But you have to like get proper history when you're talking to these people. So the kind of HPI questions that you want to always be assessing, especially in general of women of childbearing age, is last normal menstrual period. Is it regular? Is it irregular? Uh, any uh, any previous pregnancies, problems, miscarriages, sexual activity, contraception, IUD, Mirena, pills, nothing. Prior surgeries are also will place them at risk, especially tubals. And then again, pregnancy in a patient with a history of tubal is ectopic until proven otherwise. And lack of pain in women with vaginal bleeding does not exclude ectopic pregnancy. So if you get a woman of childbearing age with lower abdominal pain, vaginal bleeding, they're pregnant until proven otherwise, and it's an ectopic until proven otherwise. That way you'll never miss it. Yeah. So what kind of workup do y'all like want to do for someone that you're concerned may have an ectopic pregnancy?
HCG level, ultrasound.
Anybody else want to chime in?
Would you, if you're not sure if it's like ectopic, would you run other labs? Maybe like just a
Of
normal
course,
CBC?
right? Because I mean, like, you can have vaginal bleeding in it. I mean, like a weird case of vaginal bleeding and lower abdominal pain and torsion, or regular pregnancy. And like most common reason why why women come in with vaginal bleeding is for first trimester pregnancy. But yeah, you would get a CBC, basic labs, BMP, HCG, ultrasound, type and cross. Don't forget the type and cross because who knows? You may have to give Rogaine. Yeah, so transvaginal ultrasound. You can diagnose it with direct visualization with ultrasound or laparoscopic procedure. And beta HCG, there's the discriminatory zone that we all know that we're tested on. So 1500 to 2000. Roche for me for this year's EM says like it's now like 1500 to 3000 something. But the point is does anybody, well, it says here like the that this discriminatory zone, it says that you should just be able to see a yolk sac on the ultrasound. It does not mean that you can see a heartbeat. It just means that you should be able to see inside the uterus a yolk sac. And if you do, that's an IUP. But they need follow up to make sure like there continues to be a heartbeat and stuff like that. If you don't see that and their HCG is like 3,000 and you don't see an IUP, then it's an ectopic until proven otherwise. And yeah, the HCG should double every 2 days. So if they're stable, the disposition is stable, not anemic, not hemorrhaging, vital signs are okay. They're going home with discharge, follow up with their OB-GYN in 2 days for repeat ultrasound and HCG test. And this is kind of like what the yolk sac looks like on ultrasound. The left image is a ultrasound. It's actually a transvaginal ultrasound. It's displaying an ectopic pregnancy. That's actually displaying a ruptured ectopic. You can see the thin endometrial stripe. It's very thin. There's obviously no cavity, and then there's what the second arrow is pointing to. There's a ton of black anechoic structure. That's blood or fluid. And then on the one on the right, you can see the same thing. This is kind of like around the ampulla area. This would have a heartbeat on the ultrasound. This is another ectopic pregnancy. So if you are an astute resident or even med student, and you take your ultrasound and you plop it down, and you see something like this and like this concerned history, you can call OB-GYN and get them to the OR or into the next steps faster than being time gated by all this stuff. A little bit more about the discriminatory zone. Around a level of 6,000, you should be able to detect a heartbeat on the transabdominal ultrasound. So again, consider POCUS. Treatment, stable patient, they get methotrexate. Better success with lower HCG levels. Relative contraindications are levels around 5,000 or higher and a heartbeat. This is where I say that like kind of the laborists kind of chime in with their anecdotal stuff. I worked with one that had a threshold of HCG of 8,000. It like really just depends who you're working with or who you consult. But if the ectopic has a heartbeat, methotrexate is likely going to it has a very high fail rate. And then you want to obtain LFTs because methotrexate is contraindicated in transaminitis. And obviously, if they're unstable, they're going into the OR. So a little bit about peripartum cardiomyopathy. Not too much on it, but it is a very extreme complication of heart failure that can really occur at any gestation, but classically presents in the last month to the first 5 months of postpartum. Risk factors are advanced maternal age, greater than 40 years old, African American, chronic hypertension before pregnancy, gestational hypertension, pre-E, HELP syndrome. All these bad complications can lead to peripartum cardiomyopathy. The symptoms are your typical heart failure exacerbation symptoms: shortness of breath, rails on exam, chest pain, edema, JVD, orthopnea. The list goes on. The diagnosis and the treatment, that's the same as heart failure, acute heart failure, except you don't want to use nitroprusside. Recovery is actually very well. Within the first 6 months of diagnoses, they typically do very well, and they're able to come off of GDMT, and they're able to come off their medications and have a resolution. But sometimes that's not always the case, and then some severe cases, I've seen patients with actual pacemakers placed at like very young ages because they had this very bad complication. So it is something to be aware of. Just because someone who's 30 years old comes in with shortness of breath and otherwise healthy, don't just not think of peripartum cardiomyopathy, because it can be easily missed and bad outcomes can happen. And then the one thing we all like to kind of talk about, things we like to, I guess talk about are perimortem C-sections. And it's basically a cross section, hopefully with OB's help. And the whole purpose is to stabilize mom, you continue ACLS, and you consider doing PALS on the newborn. But that's pretty much it. I had my Tent and Alleys manual. There was a section I was reading for perimortems, and the technique is very different than what you might have seen on your OB rotation. You basically start at the fundus of the like uterus, the abdomen, and you make a vertical incision down to the pubic symphysis. And you reflect everything in there. You dissect the bladder, kind of you reflect the bladder out, and you make another incision in the uterus, and you just get the baby out as fast as possible. Hopefully OB is there to help you and actually do it while you're running the code. But in most EM jobs, they're in rural or in community places, you may not have OB in the first like 5 minutes, or you may not be able to call them and them come down immediately. They may be at home sleeping or X, Y, and Z. So this is the one procedure that, like Crikes, we like to talk about, we like to learn, but hope we never have to do it. And I don't know how we're doing on time. If anybody would like to ask questions, I mean, I can take questions for this, or I can hop over and do my PID lecture, which is pretty cool, but it's up to you guys. Oh, by the way, that's good.
Anybody have any questions?
Yes, I have a question. Can you tell us what else are the one that we want to learn and hopefully we don't have to do it other than this one? What are the other ones?
Like the procedures?
Yes.
Oh, any major procedure on a pregnant patient. So any chest tube, you don't want to intubate pregnant people. You hope you never want to do a perimortem. Um, hope you never have to do a crike or a pericardiocentesis. I can't think of much else.
Okay, that was plenty. Thank you.
Yeah. Yeah.
Well, that was awesome. Thank you, Jared. Dr.
Yeah.
Mayfield.
There's not much. You can just call me
Jared,
Jared.
do you know where you were 5 years ago? Yesterday?
Yeah, man. On the island.
Hell yeah.
Yeah, that's wild. Yeah. There's not much in regarding obstetric emergencies from our standpoint. It's just more so about stabilizing mom. And the answer, if any laborist asks you or any OB resident asks you, the answer is always the priority is always mom. So I mean, of course, you're gonna like try other stuff, right? Like lay on the left side and get pressure off the IVC, fluid resuscitation as best as possible. But sometimes things don't always work out textbook wise. So
Thank
Any
you.
other
That was great.
questions, guys? I'll stop the recording.